We have another great issue this month, beginning with an article from the New England Journal of Medicine on weekly insulin, that is insulin efsitora versus daily degludec insulin in type 2 diabetes without previous insulin treatment. This is going to be a wonderful discussion with the first author of the study. Then we're going to talk about an article from JAMA Network Open on semaglutide and opioid overdose risk in people with type 2 diabetes and concomitant opioid use disorder. Then we're going to discuss an article from Diabetes Care on the association of both diabetes and prediabetes with mortality and life expectancy in China. Then an article from JAMA on GLP-1 medication use for type 2 diabetes in the US, looking at trends. And finally, an article from Diabetes Care on healthcare utilization and cost associated with empagliflozin in older adults with type 2 diabetes, where we will be talking with the author of this study. For our first article this month, we're going to discuss a very exciting article published in the New England Journal of Medicine titled Insulin Efsitora versus degludec in type 2 diabetes without previous insulin treatment. For those of you who don't know, insulin efsitora is a weekly insulin. So this is a big change and a big deal in the evolution of insulin. Joining us to discuss this article, we are privileged to have the first author of the article, Dr. Carol Weisham. Dr. Weisham is a clinical endocrinologist and a clinical professor of medicine at the University of Washington and a past president of the Endocrine Society. Carol, welcome.
Thank you, Neil. Happy to be here.
Carol, this is a very exciting publication. And first of all, congratulations.
Thank you.
Can you give us some background about insulin efsitora?
I'd like to start with just talking a little bit about the evolution of basal insulin. As we know, basal insulin per se was first developed sometime in the approximately 1950, and it has evolved since that time from the old NPH and lenti, ultralenti, to now we have second generation insulin analogs with degludec and with glargine U300. But there are still some issues with this, in that people are still not getting started on insulin in time. Late starts and not getting to goal. So only 25% of patients on basal insulin actually get to their glycemic target. So new and improved ways of treating people with insulin is important. So there have been several different strategies. Two companies are coming up with weekly insulin, one of which is the producer of efsitora.
It's interesting when I think about when glargine came out, and I think it was the early 2000s, what a difference that made. And I think of it not necessarily so much as getting us better able to get people to goal, but making it, at least in primary care, easy for us to think about starting insulin, easy for our patients to then titrate and use insulin versus multi-dose insulin.
I agree. And if you start earlier, you get a better chance to getting a goal and you have less weight gain. So I'm trying to push people to think about insulin when they have their GLP-1s on board and ready to go on from there. Let's get insulin when their A1C's in the 7s, not 9s.
Yeah, and it makes sense. And something that you said about how delayed often starting insulin is, I remember it might be about 8 years ago now, there was this paper that came out showing that for people on 2 or 3 oral agents, and this was before the GLP-1s, it took 7 years of uncontrolled glycemia till someone actually was started on insulin on the average. So these advances are important. And I suspect that weekly insulin will also be incredibly important from a patient point of view. I think about some of the older patients that I take care of and how this might be easy, but we'll get to clinical implications later. Um, any other background before we jump into methods?
No, I think that it's important to know just Efsitora is an insulin with a half-life of 17 days. And so it is very effective for a once weekly administration.
And I guess that long half-life lets it have a pretty smooth, steady state. Is that right?
That is absolutely right. So far, of all the studies, all the insulins that have been done, this has the best steady state value day in, day out, hour in, hour out.
Yeah, not a lot of peaks and valleys in insulin amount in the blood. So, in terms of methodology, how is the study done?
So first of all, these were patients who were with type 2 diabetes who were insulin naive. They were randomized between Efsitor and degludec on a one-to-one basis and then titrated effectively. And I'll talk about the dosing in a minute. Importantly, there were CGM sessions blinded every for 2 weeks before randomization, and then several points along the study, including at the end and follow-up. So the dosing, Efsitora, because of its long half-life, if you just started it at a dose, would take quite a long time to reach steady state. And through various studies, they determined that using a loading dose of 3 times the weekly dose would be appropriate. Then the patients who were on Efsitora would get 100 units weekly, and the patients on degludec started at 10, and both groups were treated to target between 80 and 120.
Okay, and when we talk about a loading dose, because I think it's important for our listeners to understand, this is going to feel different than what we are used to with degludec 10 on day one. What was the initial loading dose for Efsitora?
So it was 300 units, 100 units for the dose, and then basically extra 200 units to get the levels up to steady state as quickly as possible.
Yeah, and when I first heard that, I almost fell off my chair. But it turns out, and in case anyone's wondering, from a safety point of view, it turns out to be fine.
Yeah, absolutely. There was no, if you look at risk of hypoglycemia in various parts of the study, first of all, they were very low. Second of all, there was no imbalance between the Efsitor and the degludec in that first 12 weeks of the treatment.
Yeah, so because of that long half-life, it's slow onset, and we're able to do that. So thanks for going over the dosing so carefully. What were the results of the study?
Okay, so there were about 1,200 patients who were screened, about 928 were randomized. They were well balanced. They were very diverse population with duration of diabetes about 12 years and A1C at baseline of 8.2. They also, I think, importantly, divided up the patients so half would be on GLP-1s and half would be not on GLP-1s because they wanted to see what the impact of that on background therapy, which I think is really interesting. The primary objective was to show that Efsitora was non-inferior to degludec in A1C change. And they did demonstrate that. The difference was minus 1.3% for Efsitor and minus 1.26 for degludec, which was not statistically significantly different. And importantly, there was no difference in those patients using GLP-1s versus not GLP-1s. They had the same relative difference in A1Cs. So having a GLP-1 on in background did not cause any issues in terms of getting to A1C to target.
Yeah, really important to know. And you mentioned the safety earlier that there was no difference in hypoglycemic rates.
That's correct. So the changes in hypoglycemia rates were very low. In fact, if you look at significant hypoglycemia, those on Efsitora experienced 0.5% of patients per year experienced a significant hypoglycemic reaction. The number was 0.45 with degludec. This was not statistically significantly different. And importantly, none of the patients had severe hypoglycemia with Efsitora compared to 6 subjects with degludec.
So these are really exciting results. Let's talk about clinical implications. How do you think this will be used? What are the clinical implications of insulin efsitora?
Well, I can think of many that might be helpful. I think you mentioned earlier about the use in the elderly population. I have several people whose children or loved ones are helping them monitor their medications, and they are on a weekly GLP-1. And if we could just get their insulin weekly, it would also help to simplify the care of these patients. I also think that there are patients, and you've probably seen them, who have type 1 diabetes who are frequently being admitted with diabetic ketoacidosis. And a once weekly has that potential where it either could be supervised or otherwise they would always have some insulin on board, and they could stop, their other insulin for 2 to 3 days and probably not get into
Hmm.
much way of problems. So I think that has a really important role in the potential for type 1 diabetes. But I have to say that studies show with once weekly GLP-1s versus daily, there's improved adherence with the weekly products. And so we would hope the same would be true. And then finally, just getting people on GLP-1s now, most patients are already on injections by the time we're thinking about insulin. So it's really quite easy to get people on insulin, but it does take a little bit of cheerleading. And I think that, again, once weekly injections, patients, some patients, perhaps many patients, will find to be more palatable than daily injections.
Yeah, I think that ease of use is going to be a big deal. It's a decade ago, we wouldn't have imagined that the bar would be set, that it would be normal to have once weekly injectables, but that's clearly what many of our patients and we've come to expect with the GLP-1s. And now the difficulty with adding insulin to someone who's already on a GLP-1 is a discussion about a daily injection, which I think it'll have. I actually think this will make things easier all around.
I just wanted to make one point because I know you and I both agree that the dosing of this is going to be a challenge for people trying to get used to this concept. But that at the end of the day, at the end of the study, the patients who were on Efsitora were on about 314 units per week, which was 45 units a day. Those on Degludec were on 334 units per week,
Mm.
or 47.8 units per day. So we're talking about, if we can start thinking weekly dosing or divide the weekly dose by 7 so you can think about it the way you're used to thinking about daily insulin. I really think that's going to help if we can just help people kind of get used to that concept.
Yeah, it will require a shift in the way we think about insulin. Carol, this was so helpful. Dr. Carol Washam, thank you so much for joining us.
It was my pleasure. Happy to do it.
For our next article, we're going to talk about an article published in JAMA Network Open titled Semaglutide and Opioid Overdose Risk in Patients with Type 2 Diabetes and Opioid Use Disorder. It is very clear that opioid use disorder is a critical issue nationwide, and we need more effective treatments for this disorder. There are anecdotal reports of reduced drug cravings in individuals using semaglutide. The goal of this study was to investigate whether semaglutide could protect against overdose in people with opioid use disorder. This was a cohort study that compared the association of semaglutide with other anti-diabetic medicines, things like insulin, metformin, DPP-4s, SGLT2s, sulfonylureas, TZDs, and other GLP-1 RAs, including liraglutide and dulaglutide, in people with diabetes and opioid use disorder. They used data from this enormous platform called the TriNetX Analytics Platform, which is a federated health research network providing access to de-identified electronic health records of over 115 million Yes, I said million patients in the United States. Eligibility criteria included patients diagnosed with both type 2 diabetes and opioid use disorder, prescribed semaglutide or the other anti-diabetic medications mentioned between December 2017 and June 2023. The semaglutide group and each comparison group were separately propensity score matched for covariates at baseline in order to emulate randomization. Follow up was from the index event until the outcome, death, lost to follow up, or 12 months, whichever occurred first. The study included over 33,000 eligible patients. Over 3,000 were prescribed semaglutide. Mean age was 57 years old. 57% were female, and there were almost 30,000 who were prescribed other anti-diabetic medications. Before propensity score matching, the semaglutide and comparison groups differed by lots of variables, but those variables were balanced after propensity score matching. And in doing so, looking at the results, semaglutide was associated with a significantly lower risk of opioid overdose during a 1 year follow up compared to other anti diabetic medicines, including all that we mentioned, with hazard ratios ranging from 0.32, so almost a 70% decrease, to a hazard ratio of 0.58. John?
So Neil, wow, right? So two huge issues that we're dealing with as a society that we're dealing with in medicine. So, that said, when you think of the GLP-1s and the effect that they have on obesity, and you see patients in the office, the satiety part is a huge part of it. And hitting those satiety centers, people don't feel as hungry. And I think that that's really one of the big actions of this class of medications. If you believe overeating, you'll believe obesity kind of falls into some of the same silos as addiction. It would follow that something that acts centrally. When we think about the treatment of addictions, the things that just kind of block the action of the medicine, antabuse, didn't work all that well, right? And people would drink over it or not take it in those days. The things that we have kind of really have found are the things that act more centrally and help kind of more with a CNS component of dealing with the medicines. Not perfect, but I think that this is exciting. Now, when I looked at the paper and said, why is semaglutide so much better than the other medicines in the category, I can't completely wrap my head around it. Also could be we're going to talk later in the episode about kind of market share, partly, and we're talking about big database, but just it's kind of been used more, and ultimately we might find out that any of the medicines in this category, but probably the medicines that are maybe perhaps have an obesity indication as well, versus some of the other ones that have not yet kind of reached that indication. Our next article is from Diabetes Care, and it was Associations of Diabetes and Prediabetes with Mortality and Life Expectancy in China, a nationwide study. So this was a national cohort study that enrolled over 135,000 patients from China who are over 18 years of age. During the period of the study, 10.5% of the patients had diabetes and over 36% had prediabetes. During a median follow-up of 6 years, there were 5,517 deaths recorded, including 1,428 and 2,300 deaths among people who had diabetes or prediabetes. Diabetes and prediabetes were significantly associated with increased all-cause mortality. So the patients who had diabetes had a relative risk of 1.61. People who had prediabetes had 1.08, so an 8% higher risk. The deaths from cardiovascular disease, diabetes had a relative risk of 1.59, prediabetes a relative risk of 1.10. Additionally, diabetes was significantly associated with increased risk of death resulting from cancer, respiratory disease, liver disease, diabetic ketoacidosis, or coma. Compared patients who were normoglycemic, life expectancy of those with diabetes and prediabetes was shorter on average by 4.2 and 0.7 years at age 40 years, respectively. The magnitude of the association of diabetes and prediabetes with all-cause and cardiovascular mortality varied by age and residence. Neil?
John, this data is consistent with other data that we have seen and talked about, and it's sobering and it leads to a very direct reminder that one, the consequences of diabetes are real and they are severe. The consequences of prediabetes, very important. Still an increase in total mortality and cardiovascular mortality, but nowhere near what happens when the glucose intolerance advances to the point where insulin resistance advances to the point where there's diabetes. So the clinical piece that conclusion that leads to is a clear one, and it's all about prevention. It's about primary prevention of people when they're young in order to prevent obesity, in order to prevent progression to diabetes. It's about all the things that you and I have talked about many times with healthy lifestyle, but also when nearly a third or more of our population has prediabetes, and John, and I have talked about this so many times, that is the absolute target group where all hands on deck. We need to do everything we can to stop that progression to diabetes. And there is so much we can do now, from data we've had for over 20 years from the Diabetes Prevention Program trial, where we can decrease progression to diabetes by about 70% with attention to diet and to exercise, to newer approaches with medicines, including things that are simple like metformin that has been around for a while, or things that are newer like semaglutide and tirzepatide that stop progression from prediabetes to diabetes. There's a lot we can do for the people who are at higher risk. Our next article is from JAMA, and it's titled GLP-1 Medication Use for Type 2 Diabetes Has Soared. This reviews data on the use of GLP-1s over the last few years, and it basically shows that the proportion of adults with diabetes who have used a GLP-1 medication has doubled between 2019 and 2022, and it actually has quadrupled from 2016 to 2022, such that among the over 26 million adults who have type 2 diabetes and receive treatment in 2022, 5.1 million obtained a GLP-1 medication, either dulaglutide, exenatide, liraglutide, semaglutide, or tirzepatide. In 2022, it's important to recognize that total spending on GLP-1s for type 2 diabetes in adults totaled over $33 billion, which was more than double the amount spent in 2019. And that came out to about $6,600 per person. John?
So, Neil, we spend an awful lot of the chunks of these podcasts really talking about things about SGLT2s and GLP-1s over the last, 5 years. So, we have been kind of singing the praises of these medicines in really a polymorphic way. And we talked about it with obesity, we've talked about it with cancer, we've talked about it with regard to substance abuse, as we did today. Some of the things, though, in just thinking about this surge, is we're coming up next year will be the 20th anniversary of exenatide every day. So not brand new medicines, right? Not something that just kind of popped up out of the COVID pandemic. These things have been around for a long time. So, why has this happened? Well, I think as clinicians, we have a certain amount of therapeutic inertia. And for people who've been in practice long enough, you're a little suspicious of something that comes new. You probably don't want to be the first doctor on your block trying something new. You probably don't want to be the last doctor on the block. And probably at this point, we've kind of caught up with that last doctor on the block. And I think because they work well, right? They're going to decrease people's A1C in that 1.5 range, which is really, up that initially using metformin or using insulin. So it works real well and has that bonus side effect of MACE, some kidney protection for some of them, and then the weight loss. But I think really, to me, what really kind of moved the needle is when you found out that all these beautiful people in Hollywood were suddenly using GLP-1s. It suddenly got that into the national narrative. And if the richest and most beautiful people are using these medicines, and it made me think of, the early days of the polio vaccine. And early on, they were having some trouble with some of the uptick. And then Private Elvis Presley got a polio vaccine, and within a month, that number went from 5 or 10% up to 70 to 80%. So, perhaps you and I are not quite the influencers with our patients as the people on social media and things like that. So, not necessarily the ways that we want to see these kind of medicines. That said, looking at the study, exenatide, which was our first, has really kind of dropped off, and I don't think any of us are using daily GLP-1s at this point. So really are some great medicines. And if you look at the new ADA guidelines and you look at how many people we have in the United States who have excess weight as part of their diabetes, it really should be easier to get these medicines for our patients. They really should cost less. They've been around a long time. And some of our government programs, Medicare and Medicaid, should be a little more embracing that we aren't just living in a two-tiered system, that if you have private insurances, this is going to be part of your journey, taking care of your diabetes or obesity. And if the government is helping with your medical care, they're really not going to be options except for a few patients.
For the last article of this issue, we have a wonderful and important article from Diabetes Care titled Healthcare Utilization and Costs Associated with Empagliflozin in Older Adults with Type 2 Diabetes. Joining us, we are privileged to have the first author of this study, Dr. Pugh Tu, who is an instructor in medicine at Harvard Medical School and a in the Division of Pharmacoepidemiology and Pharmacoeconomics in the Department of Medicine at Brigham and Women's Hospital. Welcome, Dr. Tu.
Hi, thank you so much.
Can you start off by sharing with us the background for this article? Why did you and your co-authors decide to undertake this?
Thank you so much for your question. So yeah, I'm happy to share. So we conducted this study on empagliflozin because mainly the reason is the prescription drug costs in the US have been increasing, and also empagliflozin SGLT2 inhibitors have demonstrated cardiovascular benefits, and early trials and also early cost-effectiveness studies have stated the benefits and cost-effectiveness of empagliflozin. However, there's a lack of generalizability of the early clinical trials conducted. Therefore, we would like to complement the trial evidence by providing evidence from the real-world data and based on patients and clinical practice that are generalizable to patients seen in clinical care, especially in older adults.
It's such an important area because as you point out, we have all this clinical trial evidence of benefit. What do they say? Is the juice worth the squeeze in real life? They're costly? Is it beneficial?
Right. Especially with the pleiotropic effects of empagliflozin and SGLT2 inhibitors being recognized more and more. So the question becomes whether the use of empagliflozin could translate into reduced healthcare resource utilization and cost of care in clinical practice based on population of older adults in clinical care.
Critically important question and a challenging one to get at. Tell us a little bit about the methodology that you used to look at this question.
Yeah, thank you so much. So we are comparing empagliflozin initiate. So we're basing this from the EMPRISE study, which is a cohort study. So set up as a drug safety monitoring program based on real world data. This is based on 100% Medicare data, based on older adults and other clinical claims data. This study is based on the Medicare fee-for-service data, which includes all older adults older than 65 years. And we are only studying type 2 diabetes patients. Although empagliflozin was approved for other indications, we are only using type 2 diabetes data, type 2 diabetes patients. And we are comparing empagliflozin initiators versus other alternative care, patients who initiate other alternative second-line medication, so that we compare patients that are likely to be at a more similar stage of diabetes progression. And we used a new user design, meaning that we started follow-up patients from the time they initiate medications and follow up over time to identify their cost and healthcare utilization. So we identified these cost and healthcare utilization data from Medicare claims based on older adults. Older adults their care are covered by Medicare fee-for-service, so Part A, B, and Part D claims data. We identify inpatient and outpatient care, health services utilization, and their costs, reimbursed costs.
Okay, and so how many people did you look at and what were the results?
So prior to matching, so this is based on data from the first 5 years of follow-up, from the first 5 years following market approval of empagliflozin from 2014 to 19. So this is based on over 25,000 empagliflozin initiators and over 276,000 patients initiating DPP-4 inhibitors. So all based on patients diagnosed with type 2 diabetes. So to control for confounding, we adjusted for over 143 covariates using propensity matching. So after direct 1:1 matching, so we were able to remove a lot of confounding in terms of age, race, the burden of comorbidities, baseline medication use, baseline healthcare costs, baseline healthcare utilization. So after matching, we are basing this about 23,000 patients in each arm, about 46,000 matched patients in our cohort. And we found that after extensive confounding adjustment, we observed the empagliflozin initiators have lower total costs and lower inpatient costs, lower outpatient costs that are accrued over time, over the follow-up. And all this to be slightly offset by a slightly higher pharmacy costs, and especially pharmacy costs for the glucose-lowering medications. And similarly, in terms of healthcare utilization, and also to point it out, and we found the cost savings are, especially absolute cost savings, are much higher in patients with diagnosed history of cardiovascular disease, which is not surprising. In terms of healthcare utilization, we also see similar findings. We observed lower healthcare utilization in patient days, hospitalization, emergency department visits, office visits, and about similar medication use.
So that's interesting. So taking all the variables into account, the total healthcare costs were lower in the empagliflozin group. Is that correct? Than the DPP-4 group?
Yes.
And that's so important because we live in an age of we're all attentive to resource utilization, and we are all familiar with how much all of these new medicines cost. And we want to, as much as possible, make sure we're having responsible prescribing and helping people, but also not necessarily overspending. What do you see as the clinical implications of this information?
So as these medications are being more popular, becoming more popular, so we found evidence to support that the use of empagliflozin was indeed associated with reduced healthcare utilization and costs over time. First, it complements the trial evidence and our knowledge that it could have pleiotropic effects. And it certainly complements trial data. And
Yeah, I would agree with you. It's interesting. I've when I've lectured on diabetes, of course, one of the studies that I talk about is the EMPA-REG study, among others. And EMPA-REG really stood out. It was the first exciting, positive result for the SGLT2 inhibitors for their CVOT trials. It showed markedly positive results. I think there was a number needed to treat on cardiovascular outcomes of somewhere around 1 to 30, mid 30s. And I've always, whenever I have talked about it, there is often someone in the audience who raises their hand and says, but these medicines cost so much. And it's always an open question. As you said, we have clinical trial data, but how does it work in the real world? So it sounds like you've put that together for us.
Yes, as you said, this is based on the data with much older patient populations, much higher mean age than, say, EMPA-REG outcome trial participants. And also, as you said, yes, the cause is an inhibitory factor. And we indeed found that the patients with empagliflozin are associated with slightly higher pharmacy costs. However, as we found in our results, there could be cost saving in terms of other comorbidities, other dimensions of care. So it has important cardiovascular benefits. So it indeed filled in the gap in research in terms of the cost savings.
Dr. Pugh, thank you so much for joining us. This is incredibly important information. Thank you.
Thank you.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.